Hello, everyone. Welcome to Schizophrenia Spectrum and Other Psychotic Disorders. Thank you for joining me. I'm going to go ahead and bring up the PowerPoint presentation. So bear with me for 1 second. All right, let's go ahead and get started. As with many of our trainings, we always start off with the challenges to a diagnosis, and this is no exception, certainly with schizophrenia and psychotic disorders. To start with, we must have a differentiation between psychotic symptoms and general symptoms of intellectual disabilities. Individuals may lack insight into their symptoms, or their ability to self-report is limited. Negative symptoms are often underreported because symptoms are less salient or confused with symptoms of ID and ASD. So one of the things that's oftentimes recommended under these circumstances is to gather more information from a variety of sources, sources that are close to the individual who we are talking about, and then to review the case frequently to see if there are any changes in presentation. Going on with more challenges, communication difficulties may be confusing and may impede recognition of some of the symptoms. Again, this is a central problem that we have with just about all of our diagnoses that require communication. And there are limitations to a person's ability to articulate exactly what the problem may be. There may be difficulties in distinguishing normal symptoms of ID from those of psychosis. Dementia symptoms may overlap with criteria for psychosis. And then finally, the impact of a developmental delay may present as hallucinations or psychosis. There may, in fact, have imaginary friends, and it's not really a psychotic behavior at all. Here's some of the symptoms that we'll be talking about. First, delusions, which are fixed, false beliefs that do not change when an individual are exposed to new conflicting evidence, such as grandiose, religious, or persecution. Okay, these might be some possible delusions that a person may exhibit. You may see hallucinations. Most commonly, these are auditory. Sensory experiences that have no external stimulus or trigger. Or you may see disorganized thinking, identified by disorganized speech, thought blocking, and derailment. Individuals may rapidly, for example, change topics and then give an unrelated answer when a question is asked. Further symptoms, there could be grossly disorganized or abnormal motor behavior. These are unprovoked moments of agitation, childlike behaviors, inappropriate reactions to settings or situations. For example, a person may burst out laughing or crying at inappropriate times. I want to mention here, there is a type of disorder called pseudobulbar affective disorder. Essentially, this is a disorder part of the brain. And what will happen when this part of the brain is affected is that a person will engage in spontaneously laughing uncontrollably or crying uncontrollably. About 3 years ago, I was working with a gentleman, big sort of guy. He was a truck driver, and this was at our traumatic brain injury rehabilitation center. And he had a pretty serious accident on the highway. I believe that he was changing a tire. Not that that's relevant, but he was changing his tire and he got hit on the side of the road. And his damage was a pseudobulbar affective disorder is a pretty deep sort of a TBI. And he would tell us that one of his big problems, complaints, is that at inappropriate times he would just burst out crying and he had no idea why, and he had no way of controlling it. I witnessed this one time when he was at a party, and it was a birthday party for one of our patients, and everybody was singing happy birthday. And as soon as we all started singing, he started bawling his eyes out, and he had to leave the room to gain his composure. And then he said, "This is exactly what I'm talking about. I can't stop this, and I don't know what I'm going to do." And it turns out there is medications for this type of a disorder. There is a compound that you could have mixed up. Um, and it works pretty well. We had him hooked up with this stuff, and psychiatrists followed him for some time, and it really did help him out quite a bit. There are negative symptoms that could develop. These are more common across schizophrenia than in psychotic disorders, where we see withdrawal or lack of normal function. There's a diminished emotional expression. You have very diminished movement, drive reduction, or abulia. And this is again much more common in with negative symptoms. And we'll talk more about that in terms of diagnosis and how this affects somebody with ID. The first type of disorder we'll talk about is schizotypal personality disorder, in which the person has a persistent attachment from social relationships and limited emotional expression. Typically, this begins in early adulthood. This may be accompanied by delusions, ideas of reference, misperceptions, and other behaviors that are outside the cultural norms. In situations like this, when we're diagnosing, we have to consider the impact of communication problems, the ability of a person to, once again, articulate not only the world around him or her, but what may be going on inside physiologically as these things are happening. And we take in consideration cultural variables in which some behaviors have to be looked at through the scope of understanding cultural variables that may affect a person's behavior or how they respond to certain types of situations. There are delusional disorders in which we see a presence of one or more delusions that continue for more than a month, but this lacks the schizophrenia symptoms. Okay, so we would not necessarily see catatonic behavior or disorganized speech. Behavior is not usually odd or bizarre, and normal functioning may not be impaired. A person may actually appear perfectly fine for the most part in terms of some of the mannerisms that they're engaged in. It may be accompanied by brief mood episodes, and disturbance is not due to a medical condition, substance abuse, or another mental disorder. Brief psychotic disorders involve symptoms that are similar to schizophrenia. There may be hallucinations, but with a duration of at least 1 day and less than 1 month, hence brief. The condition is not due, again, to a medical, substance abuse, or other mental disorder. Schizophreniform disorder involves symptoms that are similar to schizophrenia, again, hallucinations, with a duration of at least 1 month and less than 6 months. Again, what they're doing here is making a distinction and operationalizing the symptoms over what duration of time. It is, in a sense, a type of a rate measure because they're looking at an expand of time and how much we're seeing the symptoms. Again, there may be lacking functional impairment with this problem, and the condition, again, is not due to medical, substance abuse, or other mental disorders. Schizoaffective disorders. Here we see a presence of symptoms of psychosis and a mood disorder. It may be mania or depression, and they co-occur. Major mood symptoms are present for the majority of the illness. The delusions or hallucinations for 2 weeks or more in the absence of a mood episode during the duration of the illness. What do I mean by this? I have here also known as enough but not too much. When you're diagnosing something like this, what they're talking about here is that they co-occur, and they co-occur for an extended period of time. But as you're looking at the person's duration of these co-occurring symptoms, what you're seeing here is that there's a 2 week or more period of time in that observation period in which it seems like the mood disorder goes away. And what you see only is just delusions or hallucinations. And then perhaps 2 to 3 weeks later, back come the mood symptoms again. That's what we're talking about with the schizoaffective disorder. It can't it needs to co-occur for an extended period of time, but not too much, in the sense that there's a period of time, once again, in which we don't see mood episodes. We only see the delusion or hallucination. Once again, the condition is not due to a medical or substance abuse or other mental disorder problem alone. Okay. Substance medication-induced psychotic disorders. This is the presence of hallucinations and delusions that develop during or soon after substance intoxication, withdrawal, or exposure to a medication. Psychotic disorder due to another medical condition. This involves prominent hallucinations or delusions that are the result of another medical condition and are not better explained by another mental disorder. Disturbances are caused by clinical significant distress or impairment in important areas of functioning. Describe two particular examples of medical conditions which could give rise to this. Hyponatremia, in which there is a drop in sodium levels. And when this actually does happen, you could develop some degree of not necessarily only hallucinations, but you could actually develop some delusions and some just unusual types of behaviors as a function of this. I witnessed this one time with actually my father, who was in the hospital at the time, and he was on sodium. He was on saline, and he had some kidney problems anyway. And he's a jokester. He always was. And except this one time, his jokes were a little bit odd for him anyway. And he was talking to the nurses and trying to be humorous, but it was very strange, the conversation, and it wasn't really in reality. And I became concerned about this, and I took the doctor aside and I said, "This is not my dad. Could you run some tests on him?" And when they did, they found out his sodium levels were low. And they just raised his sodium levels, and he came back to his old self. So again, this is one type of psychotic disorder that's due to a medical condition. Another one is something called polydipsia. Polydipsia is a rare condition. Polydipsia referring to excessive drinking. Dipsia refers to drinking. Poly meaning excessive. And people who have polydipsia drink excessive amounts of water, lots and lots of water. And I'm not just talking about the ones who are walking around with, just a jug of water that they sip on all day, to kind of stay hydrated. No, I'm talking here about extreme water intake to the point at which sodium levels drop very quickly. And this is a pretty dangerous behavior. Um, I used to study this stuff in laboratory animals. It was a pathological kind of a behavior, but I was also involved in providing consultation and treatment to some patients who were in the VA hospital in Poughkeepsie, New York. This is when I was doing some work in Massachusetts. And in Poughkeepsie, the VA hospital there has or at the time there had a special unit, a special ward that was there for persons who displayed this polydipsia sort of behavior. They had other mental disorders on top of that, bipolar disorder. Some people had traumatic brain injury, but they all engaged, the ones who were on this unit, in polydipsia behavior. And on this unit, water is restricted. There are no water fountains. The sinks are locked up. The faucets are removing the handles. Toilets are locked up. You need to have special supervision and be let into the bathroom to be able to use it. And you need to have one-to-one attention there because persons can't control themselves with the water. So it's a pretty serious type of behavior that, again, is due to a possible medical condition that does develop and from time to time. And it is oftentimes we see a lot of water intake on hospital inpatient units anyway. There's a congregation around the water fountain a lot of times. Individuals are drinking a lot of water, but never to the point of polydipsia, at least that you don't see that. These are extreme cases. I'm going to describe 12 symptoms of catatonia. First one is stupor, no motor, psychomotor activity at all. Catalepsy, where a person is holding their posture against gravity. Waxy flexibility, slight resistance to positioning by examiner. Mutism, no response or very little verbal response. Negativism, that's where we see hostility or lack of response to instructions or external stimuli. Posturing, sudden maintenance of posture against gravity. Again, this is sort of close to catalepsy. Mannerism, caricature or exaggeration of normal behaviors. Stereotypy, repetitive movement or rocking. Agitation that has no external influence. Well, and grimacing is grimacing. Echolalia, where we see mimicking of speech, and echopraxia, mimicking movement. These are, again, the 12 symptoms of catatonia. We're going to talk more about this in a second. Catatonia, we could see associated with another mental disorder, such as criteria for catatonia are met when 3 or more symptoms occur during the course of a mental disorder, such as a depressive disorder. And again, what we're seeing here is 3 or more of these particular symptoms during the depressive disorder. It would indicate the possibility of catatonia. Catatonia due to another medical condition. Once again, we see 3 or more symptoms of catatonia. And the disturbance is a direct consequence of another medical condition. The disturbance is not better explained by another mental disorder, and the disturbance causes distress or impairment in areas of functioning. I worked with a young girl who was in her 20s, and this was at the Traumatic Brain Injury Rehabilitation Program that I work at in Colorado. And she had a massive traumatic brain injury, very, very severe. And she engaged in 3 of these behaviors. A lot of these behaviors were agitation, stereotypy at times, and this I should go back to this. Again, we saw here agitation, negativism, and some of this catalepsy where she's holding her posture against gravity. It was very unusual. And the psychiatry team at the time had prescribed Haldol, which in all my years that I've worked with patients with traumatic brain injury, I rarely ever see Haldol being the drug of choice to use with somebody with a traumatic brain injury. In this particular case, it was pretty much necessary. She was pretty far gone, and she really needed some pharmacology intervention, and that was what we ended up doing before we were able to get in and actually work with her and do rehabilitation and a little bit of applied behavior analysis treatment with her. I'm going to talk briefly about the prevalence. Psychosis is more prevalent in persons with ID than the general population. Levels of psychotic disorder are higher in persons with intellectual disability, 2.6% to 4.4%. This is in comparison to 0.4% in the general population. More prevalent in mild ID than in moderate to severe ID. Schizophrenia is 1% of the general population, and it's 3% of the ID population. Research, though, is lacking on the prevalence of data in the ID population. It's just not a population where they do a lot of research, particularly around psychopharmacology. In the development and course, individuals with a dual diagnosis of ID and schizophrenia are generally younger at first contact with mental health services. That's again because they oftentimes see some of the symptoms early on for other reasons that they're coming in to see the doctor for possibly work with the ID, and then all of a sudden they get spotted for schizophrenia. Okay. Presentations of schizophrenia symptoms are similar in people with and without ID, but communication issues make difficulty diagnosis and may display more negative symptoms, have a higher level of functional disability, and have more observable pathologies which may go underreported. And this is one of the things that we wanted to mention. When it comes to seeing some of the symptoms, you may end up seeing more of the negative symptoms with persons with ID than some of the positive symptoms. You may see possible higher levels of aggression in persons with ID with psychosis. Okay. So that's the possibility of the behavior that you'll oftentimes see, not necessarily verbal delusions, but you may see actual aggression. And that's one of the things that immediately gets them in to be seen into a mental health clinic is some of the higher levels of aggression. This is also true with depression, anxiety, and other kinds of behaviors that when the symptoms start ramping up, that's what's going to be concerning to the person, the family, the caregivers, and that they'll start going into getting some sort of treatment. Behavioral disorganization and impaired social functioning may be an indicator of psychosis. On differentially diagnosing, issues with similarity of symptoms of psychotic disorder and pervasive developmental disability, for example, high functioning autism or Asperger's syndrome. Okay. People with comorbid ID and ASD and epilepsy show more impaired social skills if you have all three of those particular problems. We may possibly see dementia in individuals with ID, and it's more common than in the general population. And then finally, social withdrawal and aggression may be confused with psychosis. There may be other reasons why the person's engaged in social withdrawal or aggression. I've worked with a lot of individuals. They will possibly be withdrawn socially. They may be aggressive. It does not mean that I immediately go in and start diagnosing them with psychosis. I kind of look at the environment, see what may be going on, and there may be other things that are happening here that could lead to some of these kinds of problems that we'll talk about shortly. Adults with mild to moderate IED symptoms may be overlooked during assessment, which leads to an improper diagnosis and treatment. It may lead to overuse of medication, or positive symptoms might be better explained by childhood trauma or abuse. Erotomanic type delusion disorders may be underreported because it is assumed to be immature fantasies based on somebody who has a low cognition. And then finally, adults with severe to profound ID may have gone underreported because of negative symptoms, and they appear less salient to the caregivers as opposed to positive symptoms in which the caregiver would certainly be more concerned and do something about it. Negative symptoms kind of fall under the radar a lot of times with caregivers. Talk briefly about the etiology of schizophrenia, not spend a whole lot of time on this because this could be a whole topic in and of itself. But schizophrenia may be caused by neurodevelopmental alterations in prenatal development or by genetic abnormalities. Individuals with intellectual disabilities and psychotic disorders show more impairment in social and occupational functioning compared to persons with ID and psychosis. I'm sorry, without ID and psychosis. And symptoms may be more noticeable, leading to social stigmatization and withdrawal. This is certainly the case. For years, I did a lot of work with individuals who had ID and also had psychotic behaviors or schizophrenia. And there is a great deal of social stigmatization, particularly around going into the community, accessing public transportation and other public areas. It does become somewhat problematic for a lot of individuals and very, very challenging. I'm fortunately live in a community in a county that is, I think, in some cases, a lot of times light years ahead of other communities relative to persons with developmental disabilities. So I'm sort of spoiled because there's a large number of enterprises and businesses here in my neck of the woods where there's a lot of welcoming to persons with intellectual disabilities. There are even some businesses here that are run with individuals with ID, and they are the ones who are the workforce there. It's almost it is their company, and they have just a little bit of guidance from folks who know how to run businesses and know how to work banking and finances. So they help keeping them afloat. But again, this is one of the things I'll be talking about later on in terms of treatment. What do you do with persons who have these problems? How do you treat them? What seems to work and what seems to probably not work as much? All right, I'm going to talk about assessments. Typical diagnostic systems may not be appropriate for individuals with ID, possibly due to lack of one standardized criteria for psychiatric diagnosis across the spectrum of ID. So again, there are things that just in the way that diagnostic systems are set up, there's not a whole lot of flexibility for the ID population. I'm going to describe two particular ones briefly. One is the psychopathology and autism checklist. This is a checklist for caregivers and family members. Fairly straightforward. The pack is easy to actually administer. The second one is the mini psychiatric assessment schedules for adults with developmental disabilities, the mini pass ADD. This is usually pretty effective for some of the higher functioning individuals who have a much better handle on the ability to communicate and articulate the world around them and the world within them. But it is not necessarily sensitive for persons with limited communication. It does rely a lot on getting that communication to make some of the finer distinctions of the diagnosis. All right, let's talk about treatment options. First one being pharmacology. Um, for many years, I worked very closely with pharmacology and working with psychiatry, um, working with individuals who, at the very beginning of my career, specialized in specifically in pharmacology for persons with ID and DD. And one particular individual I worked with, his specialization was persons with ID, DD, and a mental health diagnosis. So I had a great opportunity to learn about these medications. And this is going back quite some ways. This is before we have a lot of the new medications that are out there right now, which are, effective and have less side effects. Some of the stuff that I was working with the doctors was considered to be now these days old world, or what they call old school. So I'm going to kind of walk you through some of the little history here, some of the pharmacology decisions that are made, and talk a little bit about the first generation antipsychotics, and as well as the second generation. With the first generation antipsychotics, these are typical, what we call typical antipsychotics, typical antipsychotics. The primary treatment is schizophrenia and related disorders, but the use has declined due to different kinds of better drugs coming out. So this is one of the reasons why the drugs I'm going to talk about now, they're not really used. Are they available? It's possibly, yeah. You could probably still get some of this stuff. But now that we have this, what we call SGA, the second generation antipsychotics, they're called the atypicals. But let's talk a little bit about the first generation. The first kind of medication we're going to talk about are the phenothiazines. Phenothiazines were really discovered in the 40s and the 50s for the most part. I mean, that's when they really started being used. And in the 1950s, a drug called chlorpromazine, or also called Thorazine, is the brand name. This stuff was considered a miracle, and it was used to a large extent by many psychiatrists who started reporting some very significant improvement in the patients who received Thorazine or chlorpromazine. Similar drugs came out that are in the same categories as phenothiazines. One is called thioridazine. I believe the brand name for that was Mellaril. And Mellaril was very widely used when I first got into the field in the 1980s. At institutional settings, state hospitals, Mellaril was almost exclusively being used with a lot of the patients there. And we sort of knew the flow of this medication because we were on the community end of delivering psychiatric services and mental health services. We were seeing the closure of state schools and hospitals all over Massachusetts, and they were just coming out in droves, coming into work, live in the communities and residential programs, and really having better access to a social life rather than a secluded life in a state school or hospital. And many of the patients were coming out on thioridazine, on this Mellaril. The third drug was called trifluoroperazine. Trifluoroperazine. This is called Stelazine. I've only worked with about 3 patients who were on this particular medication because these patients really were much more floridly psychotic than the other patients, generally speaking, which is one of the reasons why they ended up using stelazine for these specific patients. With these kinds of drugs, I could tell you they are just as effective as atypicals. It's not like they say, well, don't use that old world stuff, use the newer stuff. It's a lot better. Well, in terms of effectiveness, these drugs were very effective. They did the trick, but they had, and they're also, by the way, less expensive if you could find them. But the thing here is that they had a much higher risk of neurological side effects. Tardive dyskinesia, TD, extrapyramidal side effects, dystonic responses and movements. All of these things, they were real. I saw many patients who were on these medications for years. They were on it from the time they were kids, and they were coming out of the hospitals and schools, and they had been on this drug for 20 or 30 years without any break. And they came out with some degree of extrapyramidal movements and tardive dyskinesia. It's the shaking hands, Parkinsonian kinds of movements, rolling of the fingers, and they do not go away. It was not unusual to have certain kinds of drugs that were prescribed alongside of these drugs to minimize the side effects of these kinds of medication, these medications. And you could sort of tell that they've been on them for a long time. Okay. Let's see here. One of the things that I also want to point out, these again with these side effects being unpleasant, when these side effects start happening and this person starts shaking, the first thing that may start thinking about is, I'm off of these drugs. I've had it. This is not good for me. These side effects are bad. And what ends up happening is that the person may take themselves off of the medication before notifying their psychiatrist or neurologist, and they may actually have a relapse of their symptoms that they were originally prescribed the medications for. So let's talk a little bit about the second generation antipsychotics, atypicals. Here we see, in general, a lower risk of extra pyramidal side effects. There is one drug that I'm going to talk about shortly, clozapine. It has a very strict monitoring protocol due to blood reactions. I won't go into it. That's all those reactions, but suffice to say, this is a very tightly monitored drug. You have to be on a registry to be able to be on this drug. And if I'm not mistaken, I think the doctors also have to be on that registry to be able to prescribe this medication, because they're specially trained to monitor these blood reactions, which could be extremely dangerous, right? These second generation atypical antipsychotics are effective against negative and cognitive symptoms, especially for treatment resistant types of symptoms. When we mean treatment resistant, what are we talking about? It means that at least 2 antipsychotics were tried and they were not effective in treating symptoms for psychosis. Okay. There is some risk of weight gain and hyperglycemia as a result of taking some of these medications. One of the drugs classic for weight gain is risperidone, and it is very widely used. It's almost like it's many of the patients that I've worked with over the past decades since the drug came out have used this particular medication in one form or another. I've seen a lot of good success from this. I've also seen some not so great success. And we've also had to use it in very, very tiny doses. Risperdal, I'm talking about, very tiny doses with some of the patients who had symptoms of dementia and who are pretty aggressive and needed to have some antipsychotic medication. But you have to be awfully careful when you're using antipsychotic medication with that population, because they're old, they're frail. So many things could happen. Falls could happen. injuries could happen. So very risky using those kinds of drugs with the elderly population. Very, very risky. Um, some treatment options relative to pharmacology. Well, 25 to 30% of individuals with ID receiving services, they do receive antipsychotic medications. And up to 48% of these individuals if they're exhibiting challenging behaviors. Studies have shown that the rate of prescriptions for antipsychotics, and this is really, alarming, and it's been this way for a long time. The rate of prescriptions for antipsychotics far exceeds the expected prevalence of psychosis in individuals with ID. And this is one of the concerns that was raised many years ago in Massachusetts about persons with ID who are being given these medications who do not necessarily have true informed consent. And they're being put on stuff that possibly could have a lot of side effects. And there's really nobody who was there to help them and assist them in making these important types of decisions. Again, as I said, many of the people were coming out of state schools and hospitals in the droves because they were closing and funding was going and being diverted from those hospital programs and restricted programs to community-based programs. It was a shift philosophically and financially in the service delivery in Massachusetts back in the 80s and the 90s. Having a diagnosis of autism and dementia or being older was associated with greater use of antipsychotics. And then again, the concern that antipsychotics are being prescribed for challenging behaviors rather than a diagnosed mental illness. There were so many times my patients had mental health diagnoses, but it was very hard to, I always question, how do you know that? This patient is not verbal. And they usually will fall back on certain kinds of Axis 1 diagnoses just so that they could actually give these medications, but it was questionable whether they really had these diagnoses or not. Here's some examples of the atypical antipsychotics. And I threw on here also a couple of the typical. So atypical ones, Risperdal, aripiprazole, olanzapine. Aripiprazole is Abilify. Olanzapine is Zyprexa. Three commonly used medications. Then we have the chlorpromazine again, which is a typical old early generation antipsychotic medication. Clozapine, which again I'll talk about in a second. Quietapine, which is Seroquel. Thioridazine, which is Mellaril, and haloperidol, which is Haldol. Okay, these are just some examples of the antipsychotic medications, a mix of atypicals and typicals. There is difficulty in the psychiatric disorder diagnosis. It increases with lower IQ scores and poor communication skills, as I was just alluding to. It's very hard to diagnose a person who is not very verbal. The first patient I worked with had an adjustment disorder, and he was on a fairly large dose of Mellaril, and he had much more behavioral problems than I would say he had psychiatric problems. But because of that disorder of adjustment disorder, they were able to prescribe the medication. But we basically treated him behaviorally by and large. So again, the communication problem does present some issues around a proper diagnosis, but that does not oftentimes stop a psychiatrist from prescribing the medication. As it should be no surprise, there's a scarcity of research on treatment. Individuals with psychosis and ID, especially data on treatment efficacy from random control trials. It just really doesn't exist for the most part. I was going to mention just briefly clozapine, clozaril. This has been shown to be effective in treatment-resistant psychosis. Again, you would use clozapine in a situation where, well, we tried Risperdal, nothing, didn't do anything. Then we tried Seroquel, didn't do anything. There's two atypical antipsychotics that were tried that didn't do anything. So that would classify this as treatment resistance. Okay. Um, so clozapine has been shown to be effective with treatment-resistant psychosis and bipolar affective symptoms in persons with ID. There are a whole lot of side effects to be concerned about, though. Anemia, leukocytosis, drowsiness, hypersalivation, tremors, disturbed sleep, restlessness, agitation, seizures, and weight gain. Um, we had a patient, and it was a very, very tricky situation to navigate. We had a patient who had a major league brain injury, and he also had a big time seizure disorder. And he also had, on top of that, leukemia. So our options of medications to try were strained by the fact that he was treatment resistant to just about all the antipsychotics except for one, clozaril. Clozaril was a game changer. And we have very good data to support that it was definitely the clozaril. We do this through AB designs in which we have them on clozaril, off of clozaril, on clozaril, off of clozaril, and we're able to literally change this guy's complete demeanor and ability to withstand and do rehabilitation with OTPT and speech because of clozaril. The problem that we faced, though, is that he had the seizure disorder and he was on very large doses of Keppra. Keppra actually seemed to indicate to us that it made him a little bit more agitated, but it was necessary to control the seizures. But even more importantly, with the increase in seizures, we had to taper down the clozaril because clozaril could lower the threshold for seizures and result in more seizures. So that was the balancing act that we actually had. We monitored the heck out of it. We had a lot of people helping us make the right decisions, but this is just a very clear tightrope to walk. I have seen clozaril with other patients, and the same thing. It really was. It is considered in many by many professionals to be the gold standard of antipsychotic medications. If you have it closely monitored, if the person is very closely watched on the blood work, I believe you have to have blood work once a week to kind of make sure that everything is okay, and you have to do that for somewhere like 3 to 6 months. So it's a good medication, but it's got to be watched. Okay. One of the things we always want to talk about, by the way, is side effects. One of the side effects of a lot of the antipsychotic medications is drowsiness. And if you're trying to teach somebody social skills and teaching them other kinds of important behaviors, you have them going to OT, you have them doing some cognitive rehab, perhaps going for speech if they have a traumatic brain injury. You may have them actually going and trying to do some work in vocational rehabilitation. There's a whole lot of options. And the whole thing here is that those medications make you drowsy and oftentimes will interfere with some of the learning. Doesn't prevent it from happening, but it slows it down because you're not really on your A game if you're kind of drowsy from the medications. Um, Again, antipsychotics are oftentimes prescribed for years and years and years. All right, I'm going to talk a little bit about some treatment options. In general, ecological treatment models, with or without ID, the notion of what we call ecological treatment models, do not lead to reliable differences in well-controlled studies. Seems to be the general trend or the general research that indicates that. And I did a lot of work when I was doing mental health work. I also worked just 2 doors down from a residential program that served persons with mental illness and dual diagnosis and comorbidity. And they did the best they could with training individuals and teaching them as best they could. Um, and what they did was a blend of what I would call here assertive community treatments. It wasn't really just one treatment model, but it was a strategy which I think worked a lot better for these individuals because it was more realistic. And these are the components that it addressed. It was broader in the scope than just one particular model. So the community treatment involved maximizing medication compliance. That was a huge one. Getting them to take their medications on a regular basis, monitor those medications, and to show up to the psychiatrist's office when it was time to have an appointment. Very, very important to do that. And to teach them to be able to do that independently. The goal was also to minimize relapse. Hence, those go hand in hand. A person stops taking their medication, it may increase the possibility of relapse. Help them to learn to meet basic social and occupational needs. So we worked a lot on social and vocational functioning with a lot of the individuals that we were working with. Enhance their quality of life was their main goal. And then finally, the real goal of promoting independent living and facility communication, community integration. Those were the 5 components of the mental health treatment team, in addition to just managing the medications. And in managing the medications, one of the things I do want to emphasize is that managing means is that when a person is doing well, you're going to try to taper the medication. It's not going to just stay on there and they're doing really well. They may need to stay at that dose, no doubt. I have no doubt about that. But a lot of times, more often than not, when a person's doing well, a psychiatrist may not want to lower the medication because of the fear of relapse. On the other hand, there are indications where the medications could be lowered because the person's doing well independently, and it was a problem of teaching them the right skills in the first place in the community that got them landed into the situation. A lot of work with therapy, with mental health therapists, psychiatric therapists, if they're looking at jobs and stuff, vocational therapy, and try to improve their quality of life. We also try to do a lot of psychoeducation. That's a big component. Psychoeducation is a billable service. I believe that the code is 90846. If it's not a patient present, if the patient is present and you're talking to a family member, it's 90847. If I'm not, I think those are the codes. In any event, these are the ways that we would approach working with these types of situations. I'm going to quickly go over some of the cognitive behavioral therapy data for psychosis. Cognitive exercises and behavioral strategies are certainly possibly useful for individuals. For negative symptoms, psychoeducation approaches usually using behavioral support and skill training. Again, we fall back on for negative symptoms, we try to teach a lot of independent skills, living skills, how to navigate the community, how to do public transportation so that they could see their psychiatrist or see their family, how to go to recreational events in the community, how to cook for themselves and prepare food for themselves. And then the possibility of medication self-management. These are the things that are oftentimes emphasized when we're trying to work with somebody for the negative symptoms. For the positive symptoms, we could try some of the more traditional CBT. We could try identifying thoughts and patterns and deciding not to act upon them, thought stopping. There is no clear consensus on essential treatment elements and no package has ever really been found to improve outcomes consistently. Let me also point out here is that the research just really isn't that great to begin with anyway. So it's not like we tried to find out if this stuff worked and we couldn't find out if it worked. We just never really tried to look to see if it was really effective or not. It's only a handful of these studies that have been done. We're lucky, though, that RCT has supported cognitive behavior therapy for psychosis. However, once again, meta-analysis failed to show any kind of support. Again, meta-analysis are these large analyses across many, many different populations to kind of see whether the effectiveness of a treatment or a medication works. I'll briefly mention ACT, acceptance commitment therapy. The results have been mixed, not much better than CBT. There is no head-to-head research and no standardized measures relative to ACT. That said, I use ACT in my practice. I use CBT, but I also use a large extent use ACT because I have found it to be pretty effective with many of my patients who have a dual have this dual diagnosis. I'm treating about 7 people, 8 people right now, exclusively using ACT, and also in communication with their doctors who are prescribing medications. Very important you get those release of information so you could open the lines of communication between therapy and the doctors who are prescribing the meds. So sometimes medication adjustments fall off the radar and it's not reported to you until maybe 2 or 3 weeks later. Oh, I meant to mention to you, and that's what they'll say to you. I think 2 weeks ago I switched that medication with another medication. Sorry, I forgot to tell you. One of the things I like to do is I like to keep the lines of communication open with the doctors who are prescribing medications. I'm going to go over one quick study, and then I think we'll just about be ready to wrap up. Bakey and Romani, these are 2 researchers who are at the Children's Hospital in Colorado. And back in 2 years ago in 2022, they demonstrated the results of collaborative treatment of psychotic behavior, delusional comments, maintained by automatic reinforcement. So what did they do when they were doing this? And what is automatic reinforcement? This is getting into some of the ABA terminology. Automatic reinforcement essentially means reinforcement that is not maintained by social reasons. Nobody is doing this behavior in order to get attention. Nobody is doing this behavior to escape and avoid or to get things in their environment. They're not using this socially. They're not using this for any secondary gain. The main reason they're doing this is because, how do you say it? They like doing it. Whether it's escape and avoidance behavior, whether it's aggression, whether it is psychotic speech, they do it because they themselves are automatically reinforced by the result of doing that automatically. It used to be phrased as self-stimulatory reinforcement, but it's more automatic reinforcement. And the best thing to think about scratching an itch, right? Nobody's reinforcing you for doing that. And if you're, out and you get mosquito bites and then you go inside and you start scratching that itch, it does bring some relief to you, right? But it's not maintained socially. Nobody's giving you anything for doing that. That is automatic reinforcement. And in this particular case, what they were looking at here was a patient with delusional comments who they would do this behavior no matter if there was anybody around, but if there was nobody around, they would still do this behavior regardless. So we're talking about a kid who's 17 years old, male, premature birth, hydrocephalus, CP, and mild intellectual disability. The researchers completed a functional analysis not to be confused with the functional assessment. It was a functional analysis. Delusional comments functionally related to auto reinforcement. Again, doing it because they enjoy doing it. They do it to maintain it. They would also find that when they engaged in delusional comments, he got attention. He would also do it for tangible, to get things, okay, objects, material things. That also showed that escape and avoidance was also involved in this behavior that was maintained. So what you got here is a big mess. It's maintained by a lot of things. Obviously, the social influence maintains this particular behavior of delusional comments, but if everybody just left the room, he would just be just as delusional, maybe even more so, than if anybody was standing in the room. They did a competing stimulus assessment to find out, is there anything that we could give this individual that competes with psychotic and delusional comments? That is, when we start doing this activity, or he starts doing this activity, delusional comments come crashing down and they don't occur anymore. So they found a couple of things worked for him: doing math sheets, playing Uno, coloring by number, looking at preferred books, and doing word searches. 5 different competing types of activities which would minimize these delusional statements. I'm going to show you some data, walk you through this. What you're looking at here are 5-minute sessions, 5 minutes, another 5 minutes, another 5 minutes, and so on, all the way down here, okay? And these are consecutive 5-minute sessions. And what you're looking at here is the duration of internal stimuli, okay? The duration of responding to internal stimuli. These are the delusional statements, going from 0, 50, 100, 150, 200, all the way up to almost 300. That's a lot of delusional statements. So this guy was the real deal, right? And they looked at various conditions, okay? And they would do this every 5 minutes. They would switch the condition, then 5 minutes later, switch the condition, then 5 minutes later, switch the condition. These data summarize essentially what those data points showed. And what we're looking at here is, let's look at the lower one right here. This looks like across all of the sessions down here, you got the least amount of delusional speech in the escape condition. That's the triangle. So you got a little bit of delusional speech here, but not a whole heck of a lot. Okay, basically 0. The next one we're going to look at is what's called free play. During free play, nobody's paying any attention, or I'm sorry, they are paying lots of attention to him. They're giving a lot of attention. They're not placing any demands on him. They are engaged with the person. Free play is actually the fun condition. It's fun in the sense that anything that's going to set this person off, we are minimizing the possibility. Sometimes a person may be more delusional to get attention. So what do? Well, just start giving them lots of attention without being delusional, and they won't need to be delusional to get the attention. You see? So that's the free play condition. And they run that mainly to see that, and what you oftentimes see in the free play condition, you get very little behavior. And that's what you're seeing down here. Relatively speaking, this is the free play condition. You didn't get much over the different trials. Okay. Where you did see more of the delusional behaviors was under the following conditions. Attention. That is, they would do this behavior, and the person would say, "What are you talking about? Why are you talking that way? That doesn't make any sense to me." That's giving attention to the behavior. All right. It's trying to get the person to check back into reality, and you're giving attention, excessive attention. And you can see here, when you give attention to the behavior, yeah, you get a lot. Okay. The other condition that you get a lot of behavior is the tangible condition. If he gets something every time he's delusional and he says, here, I don't know what you're saying, but here, why don't you take a card game? Why don't you here take a math sheet? Go ahead and take a math sheet. Go ahead and do this. All right. Um, that seemed to also raise the behavior of getting attention, getting tangibles, and then finally over here off by itself, the ignore condition. He's all by himself. Look at how much he's doing, and there's nothing in the environment happening. So this is not just behavior that's maintained for social reasons, for attention or whatever. He's doing this, and he would do this if nobody else was around. So this is one of the reasons that they looked at using psychotropic medication, because it was not going to probably decrease on its own, because by you could do environmental management, you could write a behavioral treatment plan which does not provide attention or tangibles or doesn't allow escape, but that's not really necessarily the maintaining variables. Those are add-ons. So in addressing this, they tried different kinds of medication. Okay. And what you're looking at here is the graph of essentially antipsychotic medications and competing stimuli on psychotic symptoms exhibited by the patient with schizophrenia. And you're going to see here baseline, which are drug holidays. In fact, there were 4 drug holidays that he was on. And the medication that we're talking about here, which is not listed, unfortunately, you can see here no medication under baseline. They got high levels of antipsychotic behavior. When they gave an activity schedule and gave activities and things for him to do, it lowered the psychotic behavior. Take that away and go back to baseline, psychotic behavior comes back. Introduce once again activity schedule and have him do different activities like Uno and stuff like that, behavior comes down. It doesn't go away entirely. Okay, go back to baseline. We got problems with the behavior again. Then they started to do a program called DRA, Differential Reinforcement of Alternative Behaviors. Whenever he wasn't psychotic, he got lots of attention. He got tangibles. He got things that essentially were made contingent upon the absence of behavior or alternative behaviors. And you could see it really did not have a huge effect, right? You could draw a line straight through here and see that there's really not much happening. And then at this point right here, they started clozaril, 25 milligrams. That's a typical starting point. And the next day they went up to 50. Here's 50. Then they went to 100 milligrams, then to 125. And you could see here when they started to go to the clozapine, and by the way, the DRA was still going on. That wasn't changed. All they did was include antipsychotic medication of clozaril. And as they increased the dose, the behavior came back down. Okay. Back here, what they did was to go back to baseline, no antipsychotic medication. And they immediately got an increase in psychotic speech. Come back down. Here's 150 milligrams here. Then they went to 175 milligrams of clozaril. And you could see it still had suppressive effects on psychotic speech. Here's 200 milligrams, 225, got a little bit of a bump up here. And then finally at 250 milligrams, along with this ABA treatment, okay, we see a significant reduction in antipsychotic speech. Okay. That concludes our discussion on schizophrenia and psychotic behavior. Thank you for joining me. I appreciate your time. I'm going to stop sharing my screen. There we go. All right. I hope this was helpful for you, and I hope this assists you in being able to find ways to manage this very unique population of dual diagnosis of schizophrenia and psychotic behavior, along with an intellectual disability, keeping once again in mind that communication becomes a very, very critical part of diagnosis. The more impaired the communication, the more likely it is that it's going to be seen mostly as negative symptoms rather than positive symptoms. If it's positive symptoms, you're probably going to take this individual in to see a clinician because their behavior really is ramping up. On the other hand, negative symptoms and very little speech, that's where you have situations where I think you may find individuals who do have a good deal more possible psychosis or schizophrenia. Um, but again, one of the things to think about here is ways to generate verbal behavior about the individual. And if the individual can't do it themselves, you may need to rely on a caregiver or somebody who knows the individual very well who would be able to tell you this is not the way they normally behave. This is very, very different. Okay. Thank you again for joining me. Hope to see you around soon. Bye-bye.